So I will start actually by asking the first question, which is with us, the chat box. And the question is directed to Dr. Khadija. This is from Dr. Ahmed, and he is asking, I think unpublished data are the insulin type comparison is misleading. He is talking about the insulin type. The patients who are on basal bolus insulin is usually on that combination because they have more advanced beta cell dysfunction and their diabetes mellitus is not controlled with basal insulin alone or MPH alone. Their diabetes is basically more advanced, complicated, and that's why they are in higher risk fasting. So it's a question mark to you if you understand it, Dr. Khadija, about it is practicality. What he is saying, this patient in the insulin because he is already in high risk, so he is put him in the high risk fasting.
Yeah. So thank you for the comment, Dr. Ahmed. We must remember that the data that I presented is an observational study. It's not a head-to-head comparison between the different insulins. Neither was it meant to be a comparative study between them. This was just an observational survey that we did, and we looked at the practices of our patients during Ramadan, and we recorded or asked our patients about their hypoglycemia and hyperglycemic events during Ramadan. Now, because of the nature of the survey, we cannot at present make very strong conclusions about those, but that was the observation that we saw, and it is what it is. Granted, there are a lot of other things that we need to take into consideration, such as what was the sort of access of care for the patients, say, that were on NPH or the basal bolus human insulins. So it could be that they were not reporting their hypoglycemic episodes because they didn't have the ability to do so, or have the access to do so. So I take your point, but we must remember that this again was an observational survey and not a head-to-head comparison. I don't know if Dr. Mohammed Hassanein would like to add anything else to that, because we were analyzing the data together.
Yes, thank you very much, Dr. Khadija. Indeed, it's observation, and there is so many confounding factors. For example, the use of some drugs is more than other regions, and the rates of hypoglycemia and complications in the investigators group in some places are different from than others. So it is just to give us an idea about how well did these group of patients on the different types of insulin manage. But more robust studies on comparisons of basal bolus, whether it's analog or human, are obviously required.
Prof. Akif, you would like to give that second question, please?
Yeah, okay. So the second question goes to Dr. Nazir Ahmed Mohammed. The question is, adjusting insulin dose by increasing 4 units if sugar is more than 200, or let's say 300, as it mentioned, 200, 16.7, does it seem to be incorrect conversion? He asks.
Okay, so I think the guidelines trying to do it as safely as possible. So we will have patients on relatively small doses. So if you have a patient who is, let's say, only taking 10 or 12 units of basal insulin, and you're trying to make an adjustment of more than 4 units, that may be too much of a dose adjustment for that patient. For those patients who you find that a small dose adjustment isn't sufficient, then we look at 10 to 20% of their dose. So for example, for that patient who's taking, let's say, 60 units, then you adjust by 10 to 20%. So that patient you would increase by between 6 and 12 units to achieve the requirement target. It's important to say that if somebody does have persistent uncontrolled hyperglycemia, then that patient probably shouldn't be fasting. If that's on an ongoing basis until their glucose levels have stabilized. Thanks.
Thank you. The second question for you, Dr. Nazir, also. He's asking about the use of Dr. Rahul asking about the use of SGLT2 inhibitor during Ramadan. Should we start it? We started before. What is about any data about SGLT2? It is not mentioned there, but probably this is good also.
Yes. So I think we now have data that SGLT2 inhibitors can be used safely in Ramadan. I think that was probably presented at yesterday's session. Because of the bit of a diuretic effect, it's probably better to initiate the drugs not at the start of Ramadan. And probably you'd have to educate the patients just from, if you are starting very soon, and especially in the warmer climates, like in the Middle East, to be aware of the slight dehydration risk. But that doesn't seem to be a major issue in the trials if used in the appropriate patient. Obviously, in the patient with very poor control, I wouldn't initiate an SGLT2 inhibitor right at the start of Ramadan, where you then may run into the risk of ketosis because it's an inappropriate therapy if used in isolation. But I think if that patient needs a little bit of fine-tuning, or you're trying to get him off the prandial insulin with a GLP-1 receptor agonist, and you feel there's a need for a little bit more, or he has another compelling indication, the drug can be used safely. I think Dr. Hassanein may have something to add since he's the author of many of the studies.
Thank you very much, Dr. Nazir. Yes, I agree with you. We do not recommend to start a drug that can potentially initiate or increase the rates of feeling of thirst and dehydration just a few weeks before Ramadan. So we normally say 3 to 4 weeks at least before Ramadan, avoid initiating such a type of a drug, and equally GLP-1s as well. We wouldn't advise on so. Certain other drugs, they don't cause problems in side effect profile, so it would be safer. But I really want to reflect on the poor glycemic control that we've seen in many of the data that we've presented, especially the real world data. We have a problem with hypoglycemia for many of our patients, and we don't want to use Ramadan as an excuse. The excellent data presented by Dr. Khadija from the RAJODEC trial, even patients on mixed insulin for co-formulation, they were able to up-titrate and get good control. The data I presented with the combination equally was the same process. So it's really important for us to focus on Ramadan is not an excuse to leave the patient for another 2 to 3 months with poor control.
Okay. Now the question from Muhammad Mahmoud to Ahmed Mohammed. He's asking, we give breakfast during the non-Ramadan period. He says, insulin dose at iftar in Ramadan or at sahur, do we decrease the dose of basal insulin also in Ramadan?
Okay, so I'm not 100% sure, but I think it's towards the basal insulin dose. So the basal insulin dose would, the dose adjustment would depend on the pre-Ramadan glycemic control. So for that patient who's got reasonably good control, we would recommend then a 25 to 50% dose reduction, depending on the readings, but usually around 25% is adequate. And to take that dose rather in the evening instead of the morning where possible. I don't know if that answers the question.
About the long-acting insulin, should we reduce it also in addition to give him the Yeah, that is
yes.
Okay.
Yes.
All right. Thank you very much. Before we conclude, I congratulate you, Muhammad, in the study. Now, what time you give this the combination? Is it immediately at iftar or what time? And are you planning? Planning to continue to see this effect long term, maybe for next year with the same group. So because really you get things which is good. Good control without really minimal hypoglycemia, and ideal maybe also weight loss in the future you find also. And we are not using a lot the combination also, and that is something encouraging also.
Thank you very much, Dr. Ali. It's an important study, an important combination. To have the combination of a GLP-1 and a long-acting insulin would help many patients during Ramadan and definitely out of Ramadan as well, especially those in many countries where the prandial intake of carbohydrate, rice and bread is pretty high. For your question about continuation of this, observing the same group, I don't think there's a plan for this, but perhaps we will be looking into future studies to present in the future years.
Okay.
The answer to your question about the timing, the vast majority opted for the larger meal, and for most patients, the larger meal was the iftar. So 90% took the fixed ratio combination of insulin glargine and lixisenatide at iftar.
Okay, thank you very much. Thank you very much, all our speakers. I would like to thank the chair of this session, Professor Akif from Turkey. It's a pleasure meeting all of you. And because we are short of time also, and we are a little bit late for the second session, I would like to thank you all. And I'll give the floor for my co-chair, Professor Akif, for the last word.